Hello friends, this is a case of laparoscopic cholecystectomy, ovarian cystectomy and appendectomy in same patient by 4 port. So we are introducing the varus needle through the inferior crease of umbilicus. We can see in the disposable varus needle of ethicon there is a green color that will let you know that your varus needle is inside the abdomen. Now this is irrigation, suction and hanging drop test just to confirm, and there is a ball there which will sink down. That means suction test is possible and it is positive. Now we have attached the varus needle. Here preset pressure is kept to 15 and the insufflation is started at the rate of 1 liter per minute. We can see homogeneous distension of the abdomen is started, and we will wait till the actual pressure reaches to the preset pressure. Now the pneumoperitoneum is almost complete. Approximately 3 liter of gas has been introduced into the abdomen to reach the preset pressure at 15 millimeter of mercury. Now this incision is enlarged to 11 mm over the inferior crease of umbilicus. And now we will introduce the optical port, that is 10 mm. So you have to hold it like a pistol. Head of the trocar should rest over the thenar eminence and index finger should be pointed towards the sharp end. Insufflator is connected and initial diagnostic was performed. After that we palpate the GP sternum, and the second port will be approximately half centimeter below the GP sternum, and this is also 10 mm. So we will pierce the membranous part of the falciform ligament and went to the right. After that, this is the third port, that is the mid-clavicular line just below the costal margin or just below the fundus of the gallbladder. This is 5 mm. You can tell your assistant to put that port, or you may also put yourself, and it should go perpendicular. Now fourth port will be anterior axillary line, 7.5 centimeter lateral and below the third, or at the level of umbilicus, at the anterior axillary line. This is 7.5 centimeter lateral and 7.5 centimeter below the third port, because umbilicus sometimes is displaced down, especially in obese patient. So fourth port should be 7.5 centimeter lateral and 7.5 centimeter below. So if you see, all these three ports are almost on the same line, and then we will do diagnostic, and patient head should be up and right up. And now fourth port will have the grasper, and we will start the surgery by retracting the fundus towards the right shoulder. So the assistant is introducing the grasper to catch the tip of the fundus of the gallbladder. And it is retracted towards the, you see the Rouvier sulcus We can see all our dissection should be above the rovier sulcus. Now you will hold the grasper, Hartmann pouch, and first anteromedial traction will be given, and then posterior peritoneum dissection will be started at least at up to the 1/3 of the gallbladder. Now this is the anterior peritoneum at the same level. And the left hand should give anterolateral traction. Now the visceral peritoneum of this is CBD. Here the visceral peritoneum over the cystic pedicle will be separated. If you are using harmonic, then always better to keep the Teflon jaw towards the cystic duct, so that accidentally you will not puncture the cystic duct. That process of removing the peritoneum is a process of skeletonization, and after that we will take the Maryland to make the posterior and anterior window. This is the posterior window. So that forms the posterior window, that forms the cystic plate, and at least 1 centimeter further dissection is necessary to see the lever either side, and you should confirm that the posterior angle of the calots is little enlarged. After that we will separate the duct from the artery, and always opening of the Maryland should be parallel to the duct and artery, and then this is the anterior window which will form. Now we will turn the ICG mode on, just to check that cystic duct, CBD, common hepatic duct, all is visible. You can see it is looking, ICG has stained it to green. We are using 1 ml ICG 45 minutes before the surgery, and now the artery is clipped. Tip of the both the jaw of the clip applicator should be visible. Because we will use harmonic to cut, so in the artery 1 clip is enough. Now on the duct we will apply 3 clip. We should avoid going very nearer to the CBD when you clip the duct, and the distance between first and third should be 9 mm, and the distance between first and second should be 3 mm. So 3 clip is applied on the duct, and now we will cut the artery. Because it is end artery and harmonic has its own sealing effect, so 1 clip on the artery is enough. And now duct will be cut. After that we will start separating the gallbladder from the liver, and a good areolar plane should be achieved, and first you should cut the peritoneum either side and then separate, and left hand is very important to give proper anteromedial and anterolateral traction, so that peritoneous fold can be separated first. Once you have done half of the gallbladder, then fundus grasper is no more required, and you should catch the gallbladder more near to the liver with your left hand, and then further traction will continue. Once we will reach to the last part, before doing the final cut, we should have final inspection, and you can turn the ICG mode on again. So just you can confirm that there is no duct of Laska, there is no cystohepatic duct, there is no bleeding, and then final cut will be done. After that, you can introduce a claw forceps, or that is also called gallbladder extractor, from the epigastric port, and then gallbladder will be taken out. Now this is the telescope we have transferred to the epigastric region, and we can see there is a cyst there, that is the para-ovarian cyst. We can see median umbilical ligament. This is lateral umbilical ligament, that is inferior epigastric vessel. This patient has the tubectomy done by open few year ago, and after that this adhesion of the tube has developed, and this para-ovarian cyst has actually developed paratubal on the femoral end. So in ultrasound it was showing approximately 3 centimeter cyst. Right now the harmonic scalpel is introduced through the umbilical port, and the telescope is in the epigastric port. So same port we will use for all the surgery. Now we will separate the adhesion of the cyst from the surroundings. Assistant is holding the cyst, that is, this port is the same port which was used to hold the fundus of the gallbladder. You can see the tube behind. This patient has already tubectomy done by the open technique few year ago, and those adhesion of the both the tube has developed due to this mini laparotomy for tubal sterilization. Now we can see left tube is also developing one small cyst. So we will separate that also. Care should be taken that our harmonic should not go medial to the ligament, because that area belongs to bladder. In between two medial umbilical ligament there is bladder. This is tube. We can see this is the tube of the left side from where we have separated. Pomerad technique of tube ligation was performed in this case, but this was not done at appropriate place. Actually, tube ligation always should be done on the isthmus part of the tube, but here ampullary or femoral part was used. So we will remove the tube of the right side also. Because it is looking swollen on the ampullary part as well, that portion which was, and then we will keep all these to the anterior cul-de-sac so that we can perform appendectomy. This patient has a episodes of the appendicitis in past, so requested to remove the appendix as well. So it is little swollen, so we will remove it later with the appendix itself after putting in a endo bag, because it is not coming through the 10 mm port. So better to keep over the anterior cul-de-sac this specimen so that it should not be lost. Now we will perform the appendectomy. So the harmonic again will be used from the umbilical port itself, and we will separate the major appendix. This is the tinea coli, so you must reach up to the tinea coli. After that we will use the Mishra's knot, and that configuration is 1 1 1 1 1, that is first hitch, one wind, one lock, second wind, second lock, third wind, third lock, and the grasper will be introduced through the loop, and this will be introduced with the knot pusher. We are using here Bhandarkar knot pusher, and tip of the knot pusher should go at the base on the cecum, so that you should not do any incomplete appendectomy. And appendix is ligated. One knot is enough because this is very secure knot. And then we will cut the appendix. If we are using harmonic to cut the appendix, it will seal the distal part, so there will be no any leak, and it's done. After that we will introduce one endo bag, and drop the appendix. This is endo catch from Ethicon, which has a metal ring and purse string as well. So once you will push the entire endo bag, automatically it opens. And the cyst also will be introduced in the same endo bag. And then after pulling this purse string, mouth of the endo bag will close and we will take it out. So thank you for watching this video. This was just a simple case of simple cholecystectomy, simple ovarian cystectomy, and simple appendectomy. Thank you very much.